Our next speaker is Belinda. And is Belinda here? I don't see her.
Yes, she's here.
Okay, Belinda, is your mic opened? Yes. Right, so you can look at sharing your screen so long, Belinda, if you like, while I tell you that Belinda's presentation is COVID and the low vision patient. What is the role of the occupational therapist? Belinda has worked with visually impaired people for the past 33 years. I probably have known her at least half that time. She started working at the Civilian Blind in 1987, and she worked as a supervisor at the Students of UJ with Hazel, and she's been now in private practice for the last 7 years. And I think for Belinda, the most ridiculous name is an occupational therapist, because she certainly isn't just an occupational therapist. She is the most wonderful person to have in your life if you're not coping with your functional day-to-day, whether it be in your place of work or your home. Belinda has empathy, she has insight, she's got endless patience with the patients, and we'd like to welcome Belinda to our talk. Thank you, Belinda.
Thank you very much, Claudette. I'm sorry, I just told my son to leave. I don't know if he would have agreed about the endless patience. He does. Oh, he does. Right, Claudette, is my screen showing? Can you see everything?
Perfect.
Perfect. Thank you very much for this opportunity. So 2020, we were all looking forward to 2020. As we know, 2020 is perfect vision. And this was going to be our year, the year of wonderful experiences and conferences and seminars that we were going to do. And then along came coronavirus. So who does the occupational therapist work with? All ages and stages, from the cradle to the rocking chair. Irrespective of what you are dealing with, whether it's a child or an adult, if there's an optical problem, the important things are lighting, contrast, and size. Those are a couple of the things that Hazel mentioned, and I will mention them again. The other situation that we have is cortical visual impairment, and that is where we have traumatic brain injuries, birth problems, or strokes, to mention a few. Visually, these patients have difficulty if things are visually complex, and it's very difficult for them to see. When they are examined by the doctor, they are often told that there's no problem with the eyes. The problem is the interpretation in the brain. So when you show them something, they don't react quickly. There's a latency to reacting. They often prefer certain colors, and I always like to work on that. And movement helps them. So COVID and the visually impaired patient. One of the major things for the visually impaired person is being tactile. And that's something we've got to be so aware of now, particularly when we're working with children, that they put things to their mouth, because the hands, the skin, after all, is primitive vision. Little babies take everything and feel it, and that's how they, and the visually impaired, that's how they take in information. So one of the problems then is with the sanitizers is that it is in fact causing the hands to become hard, and we need the hands to be soft and able to interpret the messages. And as Hazel said, there have been instances reported of people drinking sanitizers because of the alcohol content, and obviously with very traumatic consequences. Masks, these are another area of difficulty for the visually impaired. Those of us that wear glasses, our glasses fog up, and the other issue is that the mask tends to push our glasses slightly. And for people like me, the slightest problem with your glasses, and it distorts your vision. It also creates a problem with the field of view. And communication, when people can't see, they often feel like they can't hear. Perhaps for those patients, asking their family to wear the masks which actually have the cutout in plastic might make it easier, because they can then see when you're communicating. Transport is a very big issue at the best of times. And now, even with the e-hailing services like Uber and Lyft and all those others, the drivers are now wearing masks, so it makes it more difficult for the patient, the visually impaired person, to recognize them. And then also, whereas you could have easily got a lift with somebody, now one's not allowed to have your car totally full. Social distancing is a strange phenomenon for the visually impaired, because after all, you're always doing sighted guide with a visually impaired person, and that is now taboo. The other thing is we normally tell the patient to hold us inside on the crook of the arm, and now we're sneezing into our arms, so that's dreadful. Loneliness and aloneness, one can feel very alone in a crowd of people. But loneliness has been very difficult, particularly for the aged and for people that have been living alone. And stress has a major impact on functional vision. More about that later. Shopping. All of us had to learn more about online shopping, which is difficult because the devices aren't all that user-friendly. Bank cards, you give your card when you pay, and now you need to sanitize that card before you put it back. The extra screens between people, often the patients don't see them and bump into them. And technology is overwhelming. Believe me, even for those of us that are relatively fond of technology, it has been overwhelming. One of the things with technology is that the medical aids have allowed teletherapy, and they've had such good response that they are considering continuing with this, which will make it easier for patients around the country to actually make contact with an OT or an optometrist working elsewhere to find out a bit more. And then fear of the unknown. That is such a big one for all of us. In my wildest dreams, I did not see 2020 happening, and neither did anybody else. General anxiety is raised for everybody, and people are also less tolerant. It's difficult to plan because appointments are not always kept because of COVID. So what is low vision? Low vision, often known as partially sighted, it's the most misunderstood of all, because vision is thought of as all or nothing. So do you have low vision? Well, if you do, you might have disease or pathology in the eye or along the visual pathway. There's no medical, surgical, nor conventional optometric treatment to give you 20/20 vision. It's a permanent, irreversible loss, and you need to learn to use your remaining vision. Type of vision loss, as Hazel just said, there's loss of acuity and field loss. Loss of acuity is measured in the optimal situation, in a testing room, with good lighting, with specific tests, with letter spacing. That's not always the real world, but it gives an idea of how patients can see. Field loss, often patients are unaware that they have a field loss. They just think they're clumsy because they're falling over things. And then we have a combination of the two. Hazel spoke a lot about macular degeneration, which is one of the most common problems that we see. And those patients might also have glaucoma, which gives you the central vision loss combined with glaucoma having the peripheral field loss. So what is legal blindness? Well, the classification is 660, but what does this mean in terms of functional vision? Thanks to ESCOM, we all understand about suddenly being in the dark, literally. Low vision is a dynamic state. I have a picture here of a woman looking in a mirror, and it's the perception of things. What is important for the patient with low vision is the amount of lighting, contrast, and size plays a huge part. But what is blindness? That is that patients have no light perception and they need non-optical cues. In the field of low vision, we are interested in what the patient can see. We work from a very positive frame of reference. So what is the role of the OT? This is to assist the client to reach their highest level of independence through activity. As an OT, I want to know what matters to the patient. What gives your life meaning? I work as part of a multidisciplinary team, and in this team, everybody plays their role that they are trained for. The OT evaluates the impact of the vision loss on personal care. Can you bath, dress, choose your own clothing, interpersonal care, interacting with other people, seeing them, being aware of people in a group situation. Work is a very big one, because just because you're visually impaired does not mean you don't have a wealth of experience to give to the world. And socialization. Very often our patients complain that their friends don't understand, because as I said, it's not an all or nothing. In fact, low vision, if we take two walls, the one wall is perfect vision and the one wall is total blindness, one step away from either gives us low vision. Physical factors providing barriers to functioning are things like tremors. If a patient has a tremor, you can't give them a magnifier. If they have neuropathy, that might be difficult as well, because they have difficulty finding the controls on the devices. And then cognitive abilities. What are the patient's problem-solving skills like? There's confusion. Very often patients get devices and spectacles, but they have great difficulty knowing which goes with which and which can be used together. Remember, when the patient comes for their assessment, they are often quite stressed, which is why we like them to come with a family member. And due to COVID, that's another problem that we have now, is that the family members cannot be in with the patient. And then there's an inability to cope with new and confusing technology. For those of you who can't see, the picture that I have says a doctor may save your life, but an occupational therapist helps you live it. The referral system, the occupational therapist can get referrals from ophthalmologists, optometrists, genetic counselors, other OTs, teachers, and various other disciplines. Anybody working with a visually impaired, often the work will phone. Who do we refer to? Optometrists who have an interest in low vision. Orientation and mobility. This is a very big one. O&M is one of the unsung heroes of the field of visual impairment. It's very important to learn to orientate yourself and be mobile independently. Driving rehab. We often have patients who are allowed to drive again, but it's a good idea to refer them to an occupational therapist, and that's not me, who works with driving rehab. I will discuss that further. Neurooptometrists, these are optometrists who have a special interest in neurooptometry. So these are problems resulting from strokes, double vision, dizziness, which impact the vision. Social workers, psychologists, and counselors are very important in dealing with the grieving process. Diabetes educators, as Hazel mentioned, diabetes is a very big problem in South Africa and the world, but people don't always realize, they're told about diet and lifestyle, but they don't always understand that it's a lifestyle change. And that's where the diabetes educator comes in, helping you to understand the medical problem and how to adapt your life. And then disability tax experts. What questions should the OT ask? Does the patient know and understand their pathology? Was the loss of vision sudden? What factors affect their vision? The images I have here is sleep, the weather, and stress. These play a major role on the patient's vision, functional vision. Remember, there's a big difference between visual acuity and functional vision. You might have brilliant visual acuity, but when you're driving into the sun, you have a problem. Physical health, your eyes are part of the body. So everything that affects your body affects your eyes. Diabetes is affected by a number of factors. It's not only diet, it's stress, it's weather, autoimmune diseases exacerbated by stress. Often patients will come in and say their vision has gone down tremendously and they are so stressed about it. They are devastated about it. When the optometrist then tests, their vision has stayed the same. But when you chat to them, you might find out that a child has just emigrated, their only child. They have lost a spouse. They have been diagnosed with cancer. All these things play a major role. Very often, patients haven't visited an optometrist, let alone an ophthalmologist, for years because they were told that nothing could be done. This is not true. No matter how bad the vision is, there are always things that can be done. There are always non-optical solutions. And lastly, and most important, is what does the patient hope to get out of the appointment today? According to Elizabeth Kübler-Ross, there are 5 stages of grief. I've chosen an image which I really like. It's like strips of gift wrap, ribbon, which twirls. And that's very much like the spiral that happens when you have any loss. There's no set order and there's no time limit. There's denial, there's anger, there's bargaining, there's depression, and there's acceptance. No set order, no time limit. But when a patient tells me that, no, I've accepted my loss of vision, this is my lot, I've accepted it. That's not acceptance, that's resignation. Acceptance, and when you say, I have a visual problem, but I've got my magnifier, I've got my Orcam, I've got my e-sight, I've got things that help me live my life to the full. What are the management options? Magnification or minification. We magnify or minify into the seen part of the eye. Magnification works when we need to magnify, but if we go too big, we might be going into the non-seen part of the eye again. We also need eye movement skills. When I sit in on an assessment, I take note of when the person is reading on the chart and they miss certain letters, the letter size is the same. So it means that that letter is not falling into the seeing part of the eye. Contrast and color make a very big difference. Lighting. Often we walk into a room and the light is fantastic. Ask the person what lights they've got. Lighting makes a huge difference. 3 of the most important things are lighting, contrast, and size. And then alternative devices that we recommend. So I've said size is the most important. We use magnification for central vision loss and minification for tunnel vision. With tunnel vision, we often see patients walking with a cane because they might fall over things. Then they get on the bus and they read a book and people say cheat. No, it's that when they're reading, it's falling into the seeing part of the eye. Magnification eye movements. I've got the word something written out 3 times. And in the center, in the first one, slap bang in the middle, I've got my scotoma or blind spot. So the word something, the ET is missing. But in the next picture, I've moved my eye, and so now the SO I can't see, but I can see the rest of the word. Or I can learn to move it completely in order to move it. It's important that the patient learns where their best eccentric viewing point is. Glare is light that serves no purpose. Often you walk into these fancy buildings and they're all white with glass doors and the floors are white marble. For a visually impaired person, that is just glare shooting up all over. As Hazel mentioned, one of the important things for the visually impaired person is changing the polarity on your screen. Something that patients aren't always aware of is something called Bonnet syndrome. These are visual hallucinations, and the patients often don't mention them because they're afraid that people think they're losing their mind. These can be things such as faces, buildings, cartoons. Some people see gargoyle, and it can be really scary, but once they understand that this is part of the pathology, it's just, oh, that's what's there now. Bonnet syndrome can last generally 12 to 18 months. And to stop the hallucination, they say to move your eyes quickly side to side. Putting on the lights might help, and obviously stress can exacerbate the problem. So how does the OT help? By teaching to use the devices correctly. It's one thing selecting the device. It's another ensuring that the patient uses it. Assisting with technology, training eccentric viewing, as I just explained, and adapting devices if necessary. Reading is not only the vision falling onto the eye, it is the interpretation by the brain as well. And so the skills that are required in this are things like visual discrimination, visual memory, figure ground, visual closure, and form constancy. Visual closure is a big one. On the picture here, I have some O's, which are not properly formed, and some A's. If you have an A and you don't close it properly, people can misread it as a CL. So that's a major problem with handwriting. Then there's a risk of falls in the elderly. Balance comes from vision, from our ears, the vestibular system, and proprioception. When we are standing, our proprioceptors tell us where our body is, if we're going to stumble. But what happens with the visually impaired patients, because they can't see, they tend to shuffle and they then fall over things. So loose carpets are a big problem. Patients with a diabetic neuropathy can't feel the ground, and they often have difficulty. Your feet give you the messages, and that is why we actually had on one of our webinars the importance of regular visits to your podiatrist, because if your feet are aching, you can't get the correct messages. Shoes that are ill-fitting don't give support. On the one picture, I've got high heels. On the other picture, it's open-toed shoes, and the little toe often becomes a radar to the furniture around.
5 minutes, B.
Technology changes lives. Technology is amazing. Much of it is expensive, but you can often pick up second-hand things, or when your children are getting their new devices. People are afraid of the smartphones, but if you learn to use them, they are fantastic. Driving, the road to freedom. So what we have is that often patients will say to us, the doctor said I can't drive, but I am. If you've been told you can't drive, you may not. Because if there is an accident, you are at fault. Often the family remove the car because there's been one too many ding. Improved vision often allows patients to drive again, but as we've said, refer them to an occupational therapist trained in driving rehab, because driving is not only acuity or adequate visual fields, it requires the cognitive ability to drive and good reflexes. The image over here is a dog looking quite terrified as the elderly lady is driving, peering over her glasses. And she says, all these damned deer on the highway. And the dog says, those are people, Margaret, and you're on the sidewalk. Sport and recreation, as Hazel said, exercise is very important, and posture is very important for your breathing. Often patients complain about headaches and neck spasm, but it often comes from the posture rather than the devices. So there's adaptive sport, and also refer the patient to a qualified optometrist for sport classification. Schooling is very important. It's important how we can assist the teachers in helping the child in the class. Often children are placed in the front row, right in the center, but that might not be the right place for you. And we also give a letter requesting extra time for tests.
2 minutes, B.
Thank you. We request permission for children to take photos of the blackboard and correct placement of the child in the class. So advice for when talking to the patient, be specific. The patient is a person who's afraid of the future. If you're guiding a patient, be responsible and take time. This is probably one of the most important things. There are many apps for the visually impaired. And we have social groups, we have support groups and social media for the visually impaired. Thank you very much for your attention. There is life after visual impairment. Thank you very much.
Thank you, Bea, for that excellent presentation. You know, I've heard Bea speak many times, and there's no end to her wealth of knowledge, and I always learn something from her. Thank you very much. And I think you've stressed a lot of things that came close to my heart, is that what matters most is people. And I think that you help us to reconnect with people. And I like your comment that doctors will cure you, but OTs help you live your life. And you also mentioned your series of webinars. And if anybody who's listening is not on that list, please contact us and we'll put you on the list, because Bea and Hazel and Corin have been organizing a wonderful series of webinars. Thank you, Bea.